We're going.
All right. So welcome to the Health Innovators to Watch podcast. I think we might have some interference there. So if other people have other things going on. We have a new guest with us, Rachel Skoss. So tune in, obviously, for another awesome interview. But I am one of your co-hosts, Dr. Candace Carpenter, one of the Chief Executive Officers for the Boston Congress of Public Health. I'm also Chief Strategy Officer of BCPH, as well as one of the co-editors-in-chief of HPHR Journal, formerly the Harvard Public Health Review. But I will turn it over to my other co-host. And you are muted.
Hello, my name is Dr. Circe Lecomte, and as Dr. Carpenter was saying, I'm co-CEO of BCPH along with her, and I'm also co-editor-in-chief of HPHR Journal. I started with the journal actually in 2014 when it was founded in its current form at Harvard, and I've been with it ever since as editor-in-chief, either by myself or with another person, as I am with Dr. Candace now. Also helping to run the BCPH studio, which publishes the journal at BCPH, and also serving as Chief Technical Officer. So what a pleasure it is to talk with you today.
Yes,
Rachel.
thank you, Rachel. So I'll do a brief introduction, but inevitably it will not do you justice. So then I'll have you introduce yourself as well. So Rachel has been a research fellow in Australia. She's been a representative for the Royal Australian College of Physicians, as well as a representative for the Neuropsychiatric and Developmental Disabilities Subcommittee. Has done a number of things in terms of publishing a health literacy guide for individuals with disability, as well as helping to advocate and do other things in policy. Welcome, Rachel, but please, we'd love to get more of a background from you.
Thanks so much for the opportunity to talk to you. And I should just clarify that I'm not a member of the Royal Australian College of Physicians. I'm a carer representative for their consumer advisory group. So trying to use, I guess, my experience to advocate for consumers. So I've been in the research world for about 25 years, I think, and I really had a bit of a journey to get into my area of research, which is really looking at the interface between health and disability, or really disability and that interface with a lot of mainstream sectors, but I'm focused on health and mental health primarily. And that area became an interest for me because I'm a parent of a young man with an intellectual disability. So as I was experiencing the world, I was able to look at it from a different perspective from the usual academic one, and have a much better understanding of what families going through, and also what frontline service practitioners are trying to do as well. Which then led me to the aha moment of going, oh, health literacy, it's a thing and it's important.
Yeah, absolutely. And if I may follow up, Rachel, so we don't presume that people necessarily have a background in public health in terms of watching this show. Can you define disability, and then go into, I know there's a whole rich body of different types of disabilities, so I think people may have stereotypes of what this actually means. So going into some of those different definitions, as well as complex disability, which is something that you mentioned in your personal statement.
So disability, there's a few different models for disability, and I think it's probably important to say that from the health perspective, often there's a medical model of disability, which is often thought of as a deficit, a difference from what's average or what's normal. There's a more psychosocial model of disability, which is the one I adhere to, which I think recognises that there is diversity, and oftentimes the impact of the disabilities is more due to environmental issues. So, for example, people in a wheelchair might not be able to get into a building if the doorway is too narrow, and so on. So that extends beyond physical disabilities and into intellectual disabilities, sensory disabilities, and a variety of other disabilities. So I'm focused on intellectual disability and cognitive impairment, mainly because of my personal experience. And intellectual disability, the standard definition is anyone with an IQ score of less than 70. We won't get into the relevance of IQ tests or anything in this particular podcast, and no one's been able to explain to me what the difference between someone who has an IQ of 69 and someone who has an IQ of 71 actually is in terms of function. But let's just say that there can be some impairments in thinking, in memory, in communication, and various other things. So people may need additional supports to manage activities of daily living and to manage participation in the community and so on. So I think that's where I am in terms of disability. But I should say that there's a fantastic body of research around in disability studies, and I would encourage everybody to go delve into that research with people who know a lot more about it than I do. I'm a generalist, not necessarily deep into disability studies.
That's fascinating, what you've just described. I guess I was interested in your current advisory position, and I was wondering how that came about, had that position existed before, and just how you were connected with it.
Well, as far as the various positions I've had, I think certainly in health there is beginning to be more of a movement with patient-centered care and understanding the consumer voice. And then for people with an intellectual disability or cognitive impairment, often they are not necessarily given a seat at the table, and people will invite carers, carer representatives on. So my first foray into it, I suppose, into this advocacy space was when our disability system was changing. It was changing from block-funded service delivery through to individualised funding. And I started to realise that it was really important that people are given the skills to actually engage with that and to be able to get the best support for the person they're caring for. And a gentleman who really basically challenged me, who said, well, why don't you get involved? And so I did. So my first experience was on the Disability Health Network, which was a cross-sector group in Western Australia, really trying to improve health outcomes of people with disability. And from that experience, led more opportunities. And so currently the RACP one, I think, is a really terrific opportunity, because they're the peak body for physicians, which in Australia are the specialists. And I think I have the opportunity to really put forward that consumer voice, in particular, thinking about this group of people who are often marginalised, and try and change things for the better.
That's quite a journey that you've had there. And I guess I was thinking, you mentioned just about that educational piece around block versus individual funding. I think I have an idea of what you're talking about, but could you explain a little bit, like, the difference between block and individual funding, and what it could mean for someone who is living with a disability?
Okay, so block funding in my world was when the government would give organisations a certain amount of money to provide a certain type of service to a certain type of clientele. And it was not necessarily linked to the individual's goals or aspirations, or even in some cases needs. And oftentimes people would develop these services without necessarily asking the clients or the consumers what they would like. So that was block funding. And people with disability and their families really received services. They didn't excuse me, my just wanting to also talk.
Yeah.
They were receiving services. They weren't necessarily able to, I guess we've had to feel a bit grateful for what we were able to get and not think any higher. And then we had a move towards individualised funding. So where funding would be based on the individual's needs. And you may have heard that in Australia we've had a major reform called the National Disability Insurance Scheme, and that's moved everything to individualised funding. So pretty much we need to set goals and then they're funded accordingly. It's still a work in progress, but it does mean that there's I guess a higher requirement for families and people with disability to be able to engage with the system and to even, think about what these goals would be and how might we achieve them. And so it's changed the way people deal with it. But it has allowed for more aspiration, and I like to use the analogy of it's lifted people's eyes from their feet where they were just making sure they didn't stumble, and allowed them to look a little bit further towards the horizon. So, we can make goals which will help our son, in our particular instance, develop the skills so he can participate more fully in his life as he matures. But I should say the individualised funding then, it also took it away from being based on a diagnosis, and it's supposed to consider the functional impact of that diagnosis and provide the reasonable and necessary supports for that. So you can see then that there's a requirement for people to really be able to advocate effectively as well and navigate that system.
Yes. I want to be mindful that I don't talk over Dr. Candice, but I did want to ask about the social justice aspects and the equity access. Now that are having more of an individual, basically an individual self-determination in terms of the funds that come to you. What are some of the pitfalls that might happen in terms of someone who perhaps doesn't have an advocate like yourself, or someone who's caring for them, or is someone who maybe has felt more marginalized because of who they are in terms of demographics, or just not having that advocate. I was just the thoughts that came to mind. Perhaps I'm off base in the Australian experience.
No, unfortunately you're not. In a perfect world, of course, the system, for want of a better word, would really have a good understanding of that. But and there are some organisations, of various different sorts of organisations that do provide advocacy support, but there is still a huge risk of inequity, and some of that might just be postcode inequity in terms of people may have the need for support, but then may not be the services available in that geographical area. If people aren't aware, Australia is a very vast geographical area, and most of the population is based around a handful of cities. And so there is inequity in terms of the regions and rural experience because of the lack of service or thin service. But I think the main thing you've hit on is that need for skills. And I'm not going to suggest that people don't necessarily have health literacy skills or can't learn them, but often they haven't necessarily had the opportunity to be able to advocate. And also from the perspective of those who are making the decisions about funding, there's probably a lot of underlying assumptions that get made. And I think that's a big risk. I will say though that this reform has only really been going for about 6 to 8 years, and it is slowly maturing. And so I do hope we get to a particular point where we can have better pathways in and more understanding about the support needs of different groups. But it is a huge challenge, and I would not necessarily say that we've got it right yet. So, but that's part of the reason I'm doing what I'm doing, is trying to even up the scale a little bit and help people develop the skills that will make them more effective advocates, both those with an intellectual disability or cognitive impairment advocating for their own needs and wishes and being able to make their own decisions, and for people like me to have the skills to support them to do so.
Wonderful.
Awesome. If I may follow up, unless you had something.
Please. No.
So, Rachel, it just dawned on me, like similar to, say, the TQIA plus group, that individuals with disability are quite a heterogeneous group as well. Can you speak to some of the struggles that you've seen? So I was watching this documentary recently called Crip Camp, which is about individuals with disability here in the United States, and how they help to effectively pass the 504 Act, which basically allowed a lot more freedoms and accommodations for individuals with disabilities. But if you could speak to an Australian context or another context that you're familiar with, in terms of, is there a hierarchy of individuals with disabilities, and how does it work given that it's such a diverse group of individuals?
We have very strong peak organisations. So we have People with Disability, which is a national peak advocacy organisation. And there are various other advocacy groups related to specific conditions. So I think in terms of having a seat at the table, there are a lot of people with lived experience who are invited, or also who demand a place at the table, quite rightly. But it is a challenge, because you have governments may not necessarily be consistent in terms of attitude and approach, and also the people that I'm really advocating for are often not necessarily given an opportunity to advocate. We have some really great examples. For example, in the Down syndrome community, the various state branches have health ambassador programs where people with Down syndrome are able to advocate for themselves, and also provide training and so on around their experiences in the health system. And that's an example where I think we really should have more of it, where people are provided opportunity, first provided support to develop the skills, and then provided opportunity to really influence the way things are being done. But like any government decision, oftentimes the decisions will reflect the voices that were around that table at that particular point in time. And, I think both our countries share the male-pale-stale history of decision-making when it comes to policy. And I think that we've all got to battle to change that and make sure that the voices are heard. I guess from my perspective, part of that is trying to facilitate that to happen. Or when that's not possible, making sure that I'm at least bringing that up as look, this group are missing and this group need to be heard from as well. But I should also say it can be challenging, and I think we've seen some very good examples where people have been supported, and organisations have put supports in place for people who may have communication difficulties, providing information in accessible formats and things like that. All of those things can help reduce the inequity and help people actually identify what they want to say about something. But it takes resourcing.
Yeah. If I may segue to your health literacy guide. I know we were talking about it before the podcast started. We were so excited to actually see this guide. Can you talk about your inspiration for the guide and how you'd love to either see it evolve or be distributed?
Okay, so the guide stemmed from some research I was doing, and I might backtrack a little bit further than that and say I was a little frustrated often, when I mentioned I was on the Disability Health Network, and people will always talk about evidence-based medicine, but I'm not sure if anyone's really noticed that a lot of it really focuses on a particular silo of medicine. So it might be the silo of the hospital, for example, or the silo of general practice and so on. And when it comes to people who are receiving health services, we generally receive services across a range of different services and potentially different systems and different sectors. And so there wasn't really much understanding, I felt, of how the health of people with disability is being supported across all of those different requirements. So I had finally got a grant up to study how people with disability who live in supported accommodation settings, so these are like group homes or congregate settings, are supported with their health. And part of that was a case study with a large organisation over here, looking at what services people used and also how they were supported to get there. So, for example, did a support worker go with them to the appointment? Who paid for the transport, that sort of thing. I also did a health literacy survey along with some questions about the confidence to support different health behaviours, which went to disability support workers working in those sorts of organisations. So I wanted to look at their personal health literacy and then how did that relate to their confidence to do different parts of their job. So things like, notice that someone was becoming unwell, their confidence to talk to their boss, their next person higher up the chain about doing something, their confidence to talk to a doctor on someone's behalf, their confidence to support someone with respect to diet and exercise and things like that. And then the third part of the study was what I call a good old chat with a range of different people. So I talked to CEOs and senior management. I talked to people with intellectual disability. I talked to general practitioners, and I talked to carers of people with intellectual disability around a range of different aspects of health. So thinking about preventative care, management of acute conditions, management of chronic conditions, and then other gaps that they've observed. And of course, I was always looking for the best practice examples that they could give as well. So from that, I realised that health literacy is a bit of a thing. And I should say too, with respect to health literacy, it's some people's understanding of health literacy is more about the literacy aspect of it and whether people can read and understand information. But I like a model that's by Richard Osborne and his colleagues, which talks about a lot more skills. So including skills and knowledge, I should say. So I would encourage everybody to go and look for their writings on this subject as well. But it really takes more of a strength-based approach to health literacy. So as I was looking at all of this and realising that, there is an opportunity here to improve health outcomes if we focus on health literacy of both those direct care workers, the support workers, and also the health literacy of the organisation, it became obvious that, while there's a lot of really useful information out there on the internet, it isn't in a convenient place, one where one can go. And also people don't necessarily know what they don't know. And thanks to COVID lockdown, I didn't have anything better to do. So I just thought, I'll just pull all this information together. What would I like to know about? What do I think is important? And so using that model of health literacy that I mentioned earlier by Richard Osborne, and then also using the findings that I'd heard and recorded from my study, I just decided to plot out something, recognizing that everybody has different strengths and weaknesses. And then when you're talking about that from a carer's point of view, the person that they're providing support for also has different needs in terms of health. So I was looking for something that wasn't prescriptive, not telling anyone what to do, but could be a handy resource to dive into to find out a little bit more information. And I decided to write it in a sort of a conversational tone so that it's a little bit more accessible to people. So that was really, the genesis of it, was thanks COVID lockdown. And then as far as getting it out into the world, after I'd written the first draft, I had half a dozen or so people provide some feedback, and I restructured it and added a little bit more content and the like. And then we got to launch it last October, which was pretty exciting. So I'll say it's freely available on the University of Notre Dame website, and I'll make sure I provide a link. And really happy for it to be used by whomever wants to use it or would feel it's helpful. And I'm very excited that we're currently in discussions with an organisation in New Zealand to adapt it to the New Zealand context, because of course a lot of the health literacy is around navigating to health services, and to do that you need to have good understanding of of the health system in your area. So it's one of those things that probably needs to be adapted to specific area contexts. Got great plans of trying to get it out further, and I'm currently applying for funding to do a piece of work which would really focus more heavily on disability organisations. But working in the research settings always tricky, in that you need to spend a lot of time writing grants to try and get funding to just do something. So again, I'll make a plug if anyone just wants to fund it and provide philanthropic funding, then I'm more than happy to have a chat about that.
That's awesome, Rachel. And I would say, who would you really want to be able to utilize this resource? So as a physician, I can say, when I went to medical school, over a decade ago, that we did not have much education about disability. And yes, as you said, it was like that medical model, and it was very sparse information at that. But do you envision your health literacy guide as something that physicians can use, lay people?
Yes. So I pitched it for caregivers. So whether they're carers, family members, friends, providing support for people with intellectual disability or cognitive impairment. But also there's a lot of relevant information for clinicians or any other health professionals, and some of it, and throughout to linking to great resources that exist around the world. So, for example, there are a lot of resources that have been written in easy read, which means that information is much more accessible to somebody who has low literacy levels. There are also pictures to support the text. And there are some fantastic repositories of that around the world, but people need to know about them. So, for example, there's a great website in the UK called Easy Health, which I think is funded by the NHS, which has a whole library of things. So I'm not a fan of reinventing wheels, but I really do like to point people to where they can access these sorts of examples. And, that's something, for example, that if a health professional was struggling in terms of communicating something, that they could send somebody, they could find the links and then download what they want. Another area which I think is really important is supporting people to make decisions in shared decision making in health, which again is very contemporary side of contemporary approach to health. But people with intellectual disability or cognitive impairment may need support in their participation in shared decision making. And oftentimes health professionals have told me that they feel quite uncomfortable in determining whether somebody has the capacity to consent. And so, there's this great Canadian example which walks a clinician through the different steps to identify the level of capacity that somebody has to provide consent. And while the legislation differs from one region to another, the basic steps and understanding of how to go through this process remains true throughout. So I like to highlight those sorts of things. And to just give a little bit of background too, I think medical programs throughout the world, there's so much content that people need to get through that oftentimes things focus on being able to diagnose something, not necessarily being able to understand how do you then deliver healthcare. And so another reason why this is such important work, I think, is because there are people with intellectual disability who are dying of preventable health issues, which if somebody had health literacy, they might have been able to get them to the point of being diagnosed and treated with something earlier, and it not having such a poor health outcome for themselves. And also for clinicians to be able to look past the diagnostic overshadowing and actually look at the person's health needs in a more holistic way rather than just focusing on that diagnosis. So I think medical education is really important, both pre-service and then into continuing professional development. So I'm certainly trying to work in with groups at the moment, and to give a plug to the RACP, they're currently doing a fantastic work program in improving the training for trainee specialists around intellectual disability. So it's been a great joy to be on their working group for that project.
Mm-hmm. Yeah, thank you so much for that. I think you're muted.
Okay, I'm so sorry. I thought I had unmuted myself. Looking at the guide, it's such an incredible resource, Rachel, because it's a resource for individuals and carers, but also for providers, having the like the living checklist and then some other scales that are in there. It's also beautifully laid out, and all the text is just so easily accessible and easy to read. I just was wondering, I didn't know what was next on the horizon for you when it comes to this type of work. And I know you are going to be working with New Zealand, but do you ever envision doing a video series or expanding this into some sort of educational module?
Yes, and that's what I'm currently writing for. Look, I think it would be ideal to be able to do that. And one of the things I did do in my interviews, particularly with service providers, was understand how training would need to be delivered to organisations, because gone are the days where they could send people off on 3-day workshops or anything like that. And so part of my data we're really looking at how do we develop a suite of training that will then work for them, so that there's the practicalities of what they're having to do in their business, because they're all on very thin margins. So we want the organisations to be sustainable and improving the health literacy of the organisation and their workforce, but in a way that's not going to break their bank. So we've been having some discussions around training, and again, it's one of those areas which is probably best delivered on the floor. Currently, organisations would do training via, well, oftentimes will do buddy systems as training. So you can see that that's quite inconsistent. And I think it's really important that we focus on uplifting across the sector in a really consistent and credible way, really just to focus on the skills. And I think also then it gives us the opportunity to put in place some fantastic things that have been happening worldwide. And, I'd like to point to the great piece of work that came out of the UK from the News 2, which is the National Early Warning Score 2, which really highlighted some observations that people could take, that if people's health is, if their clients' health is deteriorating, which then gives them a much more consistent way to communicate about the health, that person's health, to a health professional. And so I think, taking a little bit of taking the subjective out of it and giving people skills and templates and resources to actually just use to make sure that health information exchange is much more appropriate and effective. And I should say, and health information exchange, of course, is two-way from the, well, actually it's a triad for people with intellectual disability often, that a person with intellectual disability, it may be the carer, whether that's paid or unpaid carer, and then also that health professional. So there's a lot of this sort of work where there are processes we could put in place that would make that more effective, and communication is vital for good health outcomes often. But yes, great plans.
No,
it is one of those things where I sort of, part of me feels like saying to health insurers, for example, look, we could do some great work around preventative care, because there are so many opportunities for prevention that are missed. And we've just, colleagues and I've just managed to get one grant which is focusing on potentially preventable hospitalisations of children and young people with intellectual disability, and there's a large health literacy component in that as well.
Well, it's just an incredible amount of work, in every sense of the word incredible, just the incredible volume that you've done already, and I know that you want to do moving forward. It's truly, you would never be done if you, so there's no dearth of things to do, but it's just everything that you're describing in terms of next steps just sounds so promising, and I can just envision all the things that could come from it. Dr. Carpenter, did you?
Yes.
Oh, I didn't know if you. I didn't know if you had anything to add. I thought I heard you. I'm sorry, you were on mute, actually.
No problem. I had a final question for myself. Rachel, so you talked about preventative care, preventing hospitalizations, and those with intellectual disabilities. If you had a magic wand and you could make whatever changes you wanted in disability research, policy, and practice, what would those things be?
Fund it. That would be the first one. I think what we really need is an environment where we're all working together to solve problems. We're not just focused on pointing out where the problems are. And that we need to recognise that we've got opportunity to use that expertise from everybody. So the way I like to work is to recognise that, some of the most profound things I've heard are from people with intellectual disability about what they want around their health and what works really well for them. And we really need to listen to that and to think about, well, how do we then support people like my son to develop the appropriate skills, and recognizing that it doesn't necessarily just have to happen when they're in hospital, that it's around, what's being taught in the curriculum around decision making, for example, around setting goals and healthy living and things like that, and that we don't want to wait until people are ill. So for people with intellectual disability, I think we really need to focus on how do we support people to develop those critical health literacy skills, which will then work across other things that people do. They're useful skills just to have, particularly as we navigate life. And I should say also, when I'm talking about health, I'm talking about health and well-being as well.
Yeah.
For carers, I feel, that there's that need to highlight all the things that we could do, first of all, to support people to develop those skills. I'm not banging on about that too much. And also the types of things that we should be doing to make sure that preventative care is occurring. So, for example, through the course of writing that guide, I realised that I wasn't actually doing what I felt I should be doing. And, I hadn't, my son was 15, I hadn't organised for him to have his own GP. So part of it was me doing some legwork to find a GP so that we could then do an annual health check and then move on from there. And so thinking about those sort of regular touchstone types of things. And I realise in a funding constrained environment, this may not necessarily be available. But having those discussions around healthy eating, exercise, the importance of that, vaccinations, doing the work to make to provide someone with the skills to cope with some of interventions. And just as an example, very early on, I was my son and I were traumatized when I was told to hold him down to have some blood taken, and now with a fair bit of work, he is fantastic. And as a phlebotomist says, better than most grown-ups at being able to cope with that, or cope with getting a vaccination or take tablets and things like that. So I think that for carers, there's certainly a lot of work around that. For service providers, I would like to see some benchmarking around preventative care. So the annual health checks, I still feel people have the right to refuse it. So I'm fine with that. But, making sure people have been offered their immunisations so that they're up to date, making sure people are able to access the preventative screenings, the mammograms when relevant, the pap smears, the bowel screenings, and so on, that are available for the broader population. And many people with disability are not necessarily accessing those sorts of preventative health measures. So I think that's a really important thing that we start to progress. And then, of course, from a service perspective in the health sector, I think it's really important that there's a recognition of what needs to be done, the supports that someone needs to actually get in the door first and then engage. And so that there's need to discuss things around making the environment accessible. And there's so many very simple things people can do that just make it much, much easier for a person to engage with a health service. So that if people can engage in a more positive way, then I think, we get a lot more preventative care. I think we're all in it together.
Yeah.
Yeah, awesome. Thank you, Rachel, so much. I mean, so many golden nuggets and everything that you just said.
Yeah. Yes. You're an incredible representative for, care for persons who are carers as well as persons with disability, and linking them to those in the provider community as well. Such an educational resource, and truly, and this is not even a question, it's just that this is like such an instrumental piece that you've created in ensuring health equity, because one thing that is made very clear with your guide is that persons with disabilities are persons in every sense of the word. They're not just folks who need services. They live lives. They grow up to be adults who have that want their own GP, as well as, you know, have sexual lives and relationships, and deserve to have healthy ones. It's thank you for doing that.
Can I just also give a plug? Because if you look through the guide and look at the resources, you'll see that it really is the United Nations. There is fantastic work going on in very many places. And all I did was bring it together, but we really need to highlight that there are some groups that are doing just amazing work. And that then provides me with the opportunity to try and make more people aware of that fantastic work. So as I said before, I'm a generalist, and there are people with really deep knowledge who are creating a piece of the puzzle that's vital. And my thanks to all of those people working in this area.
Great. Well, I don't have any other questions. Candice, did you?
So I just thought I'd do a summary, you know, from my end as well. Rachel, some of the things that I'm really taking away, and I hope that the audience takes away as well, is, as you mentioned, just the importance of carers and how they might be neglected and underappreciated, right, in terms of taking care of those with disabilities, especially being able to advocate for them and make substantial changes and influence, you know, for policymakers. The need, as you said, for skill-based health literacy, a strength-based approach. I really appreciated that. And then the need for benchmarking. And one thing that I became very aware of is in medicine, we tend to benchmark things in terms of age. Okay, you're 40 years old, you should get your, if it's a mammogram or a colonoscopy or whatever, we have certain ages, but we don't necessarily take into all those other things, as you mentioned, right? Different types of disabilities. And as I think about it, other different important aspects that can intersect with health. So I know I learned a lot from this. Thank you so much.
Yeah, and I think I also took away from this just your very thorough approach to research. When you said you not only did like a record review, but you also talked to carers, you talked to persons with disabilities, you talked to providers, policymakers. Just you covered all your bases. So,
well, I think this is the trouble with this is well, not trouble, I guess. There is a lot of wisdom at the coalface, and I think we really need to make sure that we're including that in any research, because if we're going to come up with solutions, we want solutions that will actually make positive change. And there have been, I think, from my history, some experience where, you know, in the early days where I didn't realise what the policy settings were and how the things that I was proposing may not necessarily work. So it's just really about being curious and then working together to come up with solutions that are appropriate for that particular context and that particular service or that particular population.
Wonderful. Well, thank you so much.
Yeah, thank you, Rachel. And to the audience, feel free to go to bcph.org and check out Rachel Skoss. Connect with her on LinkedIn. Definitely download her health literacy guide and follow all the wonderful things that she's doing. We'll continue to have these Health Innovators to Watch podcasts. And yes, thank you so much again, Rachel. Thank you, Dr. Searcy.
Thank you. Take care. Thanks, Dr. Carpenter.